So today we're going to look at echocardiography applications. On Tuesday, we looked at basically the physics of ultrasound used to make echocardiographic images. And today we'll look at how that physics plays out to give us some interesting applications. First of all, is there any questions to start with about the lecture on Tuesday, the physics lecture? No outstanding issues? Okay. The problem set is also on the website now that we'll be doing next Thursday morning. And we have, as we decided last class, the tutorial time will be from 8:30 to 9:30 next Tuesday, okay, before lecture, the hour before lecture. So echocardiography, to look back on how it's implemented in the clinic, we see that there's the transducer. Remember, this thing here is a phased array of those ceramic piezoelectric vibrators, and those things vibrate at between 5 and 30 megahertz, something like that, to create ultrasound. That ultrasound signal or transmission goes into the patient. Here we're looking at the patient's chest, so their heart is somewhere up here. It's looking towards their head, right, to image the heart. In this picture, this is the image that's created by sweeping back and forth. Remember the B mode image. And the transducer is here. The apex of the heart, the tip of the heart is here, and then the valve plane of the heart is farther away from the transducer, deeper in the chest. This is the left ventricular myocardium. This is the left atrium, the chamber that the blood coming from the lungs goes to, and then into the left ventricle, the mitral valve. This is the outflow tract of the left ventricle and the aorta. You can look at it in a single imaging plane, right? The imaging plane in ultrasound is going to be a few millimeters thick, maybe 5 millimeters thick, and we get a dynamic movie. If you rotate the transducer in your hand, say by 60 degrees, you get a new slice through the patient. So it's like cutting a pie, right, in different angles. As you rotate the transducer, you rotate the slice. And so we can look at different parts of the left ventricle just by rotating the transducer. So here this is the anterior wall, posterior wall, and we rotate to see a different angle of the anterior and posterior wall of the septum. Okay? You should know these basic orientations of the heart as seen on echocardiography. And one of the reasons why it's very useful to know these orientations is that when data is provided to physicians such that they look at the heart and make a clinical call, it's usually provided in these orientations. For echo, it's always provided that way. For MR and CT, those imaging physicists and imagers who are on top of cardiac always provide data in these orientations. It's easy to provide data in an arbitrary orientation with MR and CT. But cardiologists know these orientations very well. And so when they look at a movie in an orientation in one of these, they instantly understand what they're looking at, right? Which walls they're looking at in the heart. So the first orientation, and this is because they've been looking at these orientations with echo for 40 years or something, or maybe 30, right? So the transducer's up here. This is called a parasternal view. This is a view where you have the transducer looking at the heart, usually between the ribs. It's coming in from the side here. And the left ventricle is over here. The aortic outflow tract is here, and here's the left atrium. And so in artistic form, that's the view we're looking at. Echo doesn't produce images like this, though, unfortunately, right? These are gorgeous. You see it cuts off the left ventricle. The tip of the left ventricle is cut off, so you just see a bit of the septum, some of the right ventricular outflow tract, not really the right ventricle. But you do get a really nice view of the mitral valve and the aortic valve, so you see if those two valves are functioning well in this view. It's called a parasternal view. And then you move the transducer down away to below the ribs and look up towards the heart from the apex of the heart to get the left ventricle, the right atrium, and left atrium all in one view. So that's cutting right through the center of the heart. And that is called the four-chamber view for obvious reasons. Here's the myocardium and the atria. For this view, you can see the wall motion of the septum, whether or not the muscle is functioning correctly, and the RV, the relative volumes. And you can see both sets of valves, whether or not they're functioning well. You should know these parts of the heart that are labeled on these diagrams. What is the inferior wall? What is the septum of the ventricle? Here's the septum. It's the muscle that's between the two chambers, the apex, valve plane, etc. And then if we rotate 90 degrees and look right down this line here, we will get the two-chamber view of the heart. And so now we're sampling two different walls of the left ventricle, so this is different muscle we're watching move. Here's the anterior wall, apex, and we get a different view of the mitral valve, right? And you still see the left atrium. So essentially, in these three views, you see 6 independent chunks of the left ventricular muscle, because each one of these views is rotated, you know, about 60 degrees or something like that. Okay. Is that pretty clear? Good. The other, here's another cartoon of what those views look like with respect to the geometry of the heart itself. 1, 2, and 3 are the long axis views of the heart that are up here. This view is the parasternal view, and they're 4-chamber and 2-chamber views. And then we have 3 other views of the heart, which are the short axis views, and they cut the heart perpendicularly to these long axis views. And the heart looks like a donut. The diameter is, you know, a maximum at the base, gets smaller as we move towards the apex, smaller still down towards the bottom. If the heart is a clock face, we are looking at the heart from the patient's feet, and we're looking up towards the base of the heart from the apex. So from the feet of the patient towards the head of the patient. And in these views, we're looking right up the barrel of the heart, and the right ventricle is on the left side of our picture. And so the patient's right arm is over here, the patient's left arm is over here, and their chest is up here. Okay? Because of, you know, digital imaging, and you have a 3-dimensional digital representation of the heart, you can view it from many different angles, right? We can view it from the base towards the apex. We can, you know, review it from the anterior towards the inferior, etc. So it's important to know these orientations and always display your data in these orientations. Otherwise, people will get confused, right? You can imagine you could flip one of these such that the anterior wall of the heart was down here, i.e. the patient was upside down, and her chest was down here. It would look relatively similar because it has symmetry along this axis. And now you flip the heart over and you're getting the wrong darn call, you know, because you've got the wrong, you're naming the anterior wall the posterior wall, right? So you got to keep this clear. Right? And it's you have to also remember that in C, when you're programming C, and in MATLAB, matrices can get indexed in different orders, right? So when you take a data set and you're manipulating it with a C program and then you chunk it over to MATLAB and you read it in, it may have different orders of the array indices, right? And so the heart may be mirror reflected through some axis, and this happens all the time. So you got to always check this, make sure you're in the right orientation. Okay. The other thing that is labeled on here, and we'll look at this in greater detail, are big segments. So you cut the short axis into 6 different regions. And you have these big chunks, the anterior lateral, anterior, anterior septal, inferior septal, and inferior. And then inferior lateral. So you cut the septum into 2 big chunks, the free wall into 2 big chunks, or the lateral wall into 2 big chunks, and then the anterior and inferior. And the reason they're cut into these big chunks and labeled is usually when you're looking at flow deficits, the resolution that you measure those flow deficits is kind of on the scale of these chunks. And that's historically from nuclear medicine, where the resolution is about the resolution of these chunks, right? And in MR and CT, and for a lot of echo machines, the resolution is much higher than this, but those chunks have traveled with cardiology for years and years, and people use them as their map coordinates. So when they say, oh, there's low flow, and their colleague says, where is the low flow? They will name one of these chunks, right? So you have basal, mid, and anterior, and then in the clock face direction, you have these 6 chunks, right? So usually you only have 4 down here, so the total comes to, 16 or so chunks. Okay, any questions about that? Okay. To look at those different regions, it's pretty simple. Well, it should be pretty simple with echo. You just tilt the transducer or translate it on the chest, and you look for a window between the ribs, and you get your angle set appropriately such that you're sampling the chunk of tissue that you'd like to look at. And here, if we're looking through the ribs down towards the heart, we can see a short axis view in the mid ventricle, and then this is the base, and then this is up towards the valves just by tilting our transducer. Right? So those slices through the heart are not parallel, they're different angles, but it's not really that vital in echo to get everything parallel and lined up and things like that. You just want a good view, usually, in real time of what you're looking at. And most of the time, the thing that gets in your way is the fact that perhaps the person doesn't really have a good space between their ribs, and you can't get a good window, it's called, to get through there. Or the patient has 4 inches of adipose tissue between their skin and their ribs, right? So they're big. So if their BMI is 30, it's the person's like 5'10" and weighs 300 pounds, you have a long distance between where your transducer is sitting on the chest wall and the ribs. And so getting up a window through the ribs is kind of difficult, right? Because they're far away from your transducer. And so that, for people who are relatively obese, or you can't get a good view with the transducer, you throw up your hands and you take them to MR, magnetic resonance, where you can see all the way through without any problems. Right? So here's some examples of, this is a short axis view where the transducer, is on the chest wall looking down to get this picture. But then if we look at cutting the heart down this red line by rotating our transducer 90 degrees, we would see this view of the heart. And so here's the left ventricle, the right ventricular outflow tract, the aorta, the left atrium, and the mitral valve and the aortic valve. Okay, and that's right down the center of the ventricle. And these signals here, so this is the left ventricle in the short axis view, and we've tilted the transducer so that we're up towards the valve plane, and we're seeing these valve leaflets here, and they're open at this point. So these valve leaflets are the mitral valve. Okay? And then we'll see, as we go higher, you would see the outflow tract and the aortic valve, but these are the mitral valve. That's these leaflets here. Okay? So this image, this red line is probably, somewhere down here. If we tilt this way, we can look at the right ventricular outflow here, right ventricular outflow tract. If we tilt our transducer this way, if we tilt this way, we can look at the right ventricular inflow, which is here, right, from the right atrium into the right ventricle. So basically, as you can see, good echocardiography is really dependent on a skilled operator. The person has to have good hands, understand cardiac anatomy, and have a steady, sort of smooth ability to seek things out with an echo transducer. And watching a good echo tech work is great. I mean, they're very, very good at it, the experienced ones. Right? So here's, if you want to look at some, dynamic video. I think we looked at some of these on Tuesday. But this is just one example website. I would recommend you go to, if you want to see the best echocardiography, because these are all the cases that are, 5 sigma on the quality axis, 5 sigma positive, right? They're not average quality studies. They just show you they're amazing studies, and it's pretty remarkable. When it really works, it looks great. Again, this is a website on the Siemens healthcare website that shows many of the functions of echocardiography. I think I have it up here. Was it? No, it's not that one. Yeah, it's this guy. So if you go to this website, Healthineers, this is a terrible word, right? It's Siemens Healthineers. I think that it was lost in translation between German and English, like why you would call people Healthineers. But anyway, so there's a lot of examples here of what their ecosystem can do. So here's sort of fundamental image quality. And as we saw on Tuesday, you can see the image quality decreases with depth, right? Because recall that there's a focal point, right? When we're sweeping back and forth, there's going to be a focal point, and there's going to be a loss in signal amplitude as we go deeper. So those two effects are causing image quality to decrease as we get down here. So you can see this boundary is pretty blurry, whereas this boundary is super sharp, right? And really, you've got a high signal to noise estimate of where that boundary is, and lower down here, farther away from the transducer. Here, this is a needle inside the right atrium poking through to get into the left atrium. So it's using ultrasound to guide actual cardiac interventions where you want to make sure you're pushing the needle through the right position in the wall between the two atria. You don't want to have the needle pointing in the wrong direction when you do that, right? Because if you pushed it, in the wrong direction, say you pushed it posterior, right? So here I have my heart here, and I want to cross the septum from right to left, and for whatever reason my needle got bent, and now when I push, I'm going to go anterior to posterior. What do you think I'm going to hit? I go anterior to posterior. Well, there's a bunch of stuff down there you don't want to hit, right? You can hit the esophagus, or you can hit the aorta. Either one of those things, you don't want to put a needle in it, right? So you want to take a look and say, which way is my needle pointing before pushing across, extending the needle out and pushing across some tissue. And so in that way, okay, I'm in the right position on the septum, like to get the minimum thickness of the wall, and my needle's pointed in the right way, and you jump across. And this is classically a way that you get from the right circulatory system, which is low pressure, doesn't bleed out very easily, to the left circulatory system to do some kind of intervention. The left circulatory system, if you want to get in the left ventricle, the left atrium, whatever, if you come on an arterial pathway, you're working in a high pressure system. If you come from a venous pathway, you're working in a low pressure system. So oftentimes they come through the right side. Here's another example of, this is 3D echo, where you don't just sweep to make a 2D picture, you sweep in two directions to make a 3D picture, right? So now we're going to start running out of data. If you look at the frequency with which we were getting those B mode data, now I want to sweep that over a 3D volume and make a 3D picture, right? So there might be a problem in the problem set about that, just like what frame rate do you expect from a 3D ultrasound picture? Here we're looking down towards the root of the aortic valve, and this software that comes with the system is built so that you can measure very accurately the dimensions of the root of the aortic valve before you attempt to put a prosthetic valve in that position. So the prosthetic valves come in different sizes, say 23 millimeter diameter up to 29 or 31 millimeters in diameter. You have them on your shelf. Before you open the package, which is $10,000 or something, make sure you get the right one and put that in so that it stays. It's not a huge deal if it's the wrong size. You just take it out and get the next one. But you would try and get the right one on the first try. And then looking at Doppler, so here, this is the left atrium. Left ventricle would be up here. Our transducer's up here. And we're going to look at velocity across the mitral valve. Okay? And so on this axis, we'll actually plot the maximum velocity measured in this jet right here. Right? And this is time on this axis. Let me turn on the pointer. Oh, I don't have I'm in. So this is time on this axis, velocity on this axis. Velocity up means towards the transducer. Right? Velocity below this line means away from the transducer. So what's happening? So I'm looking at the mitral valve. I'm measuring my peak velocity right down this zone here. And my velocity is increasing and hits a peak value at this time. What do you think is occurring at that time? We are filling the left ventricle with blood from the left atrium, and it's pouring in this way towards the transducer. So it's coming through the mitral valve and into the left ventricle at this velocity, right? And then as the ventricle fills, that velocity drops down until finally there's no net flow across that valve anymore. And in fact, the ventricle, because now it is moving the valve plane itself as the velocity of the blood is filling the ventricle, as the velocity decays away, the ventricle continues to move north, the valve plane, right? So the valve plane is moving up as it's filling, the velocity is going in the opposite direction, but then the momentum of everything just keeps carrying it on, and so we see this negative velocity here, right? And then we have diastasis at this time here, so everything's at rest, waiting for the next heartbeat, and then the atrium contracts. and it pumps velocity. The atrium does a quick contraction and pumps velocity into the, or pumps blood, I'm sorry, into the left ventricle. It's called atrial kick, right? However, the net velocity you see is up, away from the transducer, because again, the ventricle moves, the valve plane of the ventricle moves up when the atrium does that. So it seems like the net result is a negative velocity, and then it starts to fill, right? Okay, so this is echo fused with X-ray. We won't do fusion, but you can imagine how helpful that is. If you're doing a intervention under X-ray guidance and you see an echo image with your interventional tools in the echo image, because under fluoroscopy you don't see any soft tissue. You don't see any myocardium or valve planes or anything like that. You just see all your gear, all your devices, and you can inject contrast and see where the contrast goes. But if you have an echo transducer in the field of view, you can then image tissues. So for instance, I think this is, I don't know what this is actually. I should have known, but I don't know what it is. But you can see the soft tissue and then map it to where, you know, this viewport is in your fluoro. And that's the whole setup. You have an echo system here and a fluoro system here. This is often done now in cardiology, where you have echo support for your intervention that you're doing under X-ray so that you can see soft tissue. Okay, so that's a few examples. Let's go back to this. And so here we see two-dimensional echo images. This looks like a mitral valve again. And on this side we see three-dimensional images. And I don't know if the movie, oh, the movie's in here, good. So you can see the Doppler signal through the mitral valve. Sorry about that. This is like marketing material. But it's beautiful data. And yeah, let me go back here and pause it. And then on 3D, you see the valve plane here with the blood, with the fluoro, or the Doppler data superimposed on top of it. So that's pretty cool. That's a pretty nice application. And here we have a classic parasternal view, measure dimensions very accurately to determine cardiac function. We can come up here, and then remember the M mode. This is an example of across the left ventricle, just below the mitral valve plane. This is the contraction of the muscle here. Okay? And then here's the opposite wall. So this is close to the transducer, farther away. So this wall moves towards the transducer when it contracts. This wall moves away from the transducer, and the dimension of the ventricle gets smaller during contraction. So you can measure all that quantitatively. Let's see what else we have. And then again, this is velocity data across the tricuspid valve. This is the mitral valve over here. This is the tricuspid valve. And you can measure it hits a peak velocity and then decays away. And then this decay curve can give you information about the physiology of the pressures in the ventricle. Okay. So here's an example of three-dimensional echocardiography. And we see both valves in this view. All right, so at this location, let me turn on the, oh, sorry. This location here is the LV outflow tract, and this is the left atrium, and these are the leaflets of the mitral valve here. And so when we turn that movie on, oh, why won't go? There we go. we can see the leaflets of the aortic valve closing and the leaflets of the mitral valve closing. This is rendered in 3D because the data was obtained in 3D. And so we essentially, you can think of this as a set of 2D images. So you make a 2D image, and then the transducer automatically changes the angle of that 2D image to a section of tissue that is next, and then the next slice, and it just sweeps back and forth. So it's like you have a fan, and you're rocking the fan back and forth this way to make a 3D volume. If you want to make a 3D volume like this with relatively high resolution, a number of systems require that you do that data collection over a set of beats, maybe 3 beats or 4 beats, because you can't scan the entire heart inside the time resolution you would like to play your movie. So if we're doing, 6 frames a second, that's like 150 milliseconds to acquire each frame. So can I, in 150 milliseconds, acquire all the ultrasound data from a single volume? And for some systems, it turns out you cannot. And so you'll take 3 heartbeats, and you'll sample a section in heartbeat 1, another section in heartbeat 2, and another section in heartbeat 3, and paste all that together. Assume those 3 heartbeats provide identical motion, and look at that movie. That seems like a pretty bold assumption, that each heartbeat, the motion is identical. But the assumption is true in a normal heart where you don't have arrhythmia and things like that, down to probably a couple of millimeters, right, down to 2 millimeters, something like that, 2, 3, that the heart will go back to the same pose on each beat. Particularly if your heart rate is locked at, say, 65 beats per minute, and every beat occurs with the same R to R interval, that means that the volume inside the ventricle is probably the same each time, and so the heart returns back to its same condition each time. In order to do that, you would have to ask the patient to hold their breath, because you don't want the heart to move around due to breathing when you're trying to collect these multiple images of the heart. Okay? This is not something that's unique to echocardiography, this assumption that each heartbeat is the same and that we're going to use multiple heartbeats. This is also used in magnetic resonance imaging. And most of the time, to get a really nice high-resolution magnetic resonance image, you need at least 8 heartbeats, something like that. And you put all the data together from 8 heartbeats or 16. CT, it used to be that you would require about 3 heartbeats. Now that these CT scanners have very large detectors, if you have a large detector, you can get it all on 1 beat. So it simplifies your life, right? And it also makes the data much more stable and robust. So any questions about that?
For the 1 beat CT scans, how much radiation are you exposing the patient?
So that's a great question. It is, for a 1 beat CT scan, how much radiation do you expose the patient to? And usually less than for multi-beat CT scans, right? Because you basically only need 1 turn of the gantry in order to make the picture. And so when everything works right, when the patient is relatively slim, when you can get all of the data you need for, say, a coronary angiogram in 160 milliseconds, you only need the x-rays on for that 160 milliseconds. And so the dose drops remarkably, and it drops down to about 1 millisievert, which is 1/3 of the background radiation you get just by being alive for 1 year. So walking around San Diego, you absorb 3 millisieverts of radiation per year of your life, right? And to do this would be 1 millisievert. Now that's CT. There is no radiation with ultrasound. There's just heating, but I don't think anybody has measured any deleterious effects of ultrasound heating for echocardiography. You can actually use, as I said, ultrasound heating for therapeutic tissue ablation for tumors, for example. You ablate the tumor. And ultrasound is used in physiotherapy to heat up muscles. So they'll put an ultrasound transducer. Say you've got shoulderitis. They just put the ultrasound transducer on your shoulder and heat it up with the ultrasound.
For those 3D CTs that we've seen
Yes.
in the slides, are those using contrast, or is that just like a higher dosage so you can actually see the tissue?
So the question is, the 3D CT we've seen so far, and you'll see momentarily, there is contrast agent used in order to opacify the blood so that you see the details of the coronary vessels and you see the details of the ventricular chambers. Yeah.
Is there anything stopping for 3D ultrasound just running all slices in parallel, or is that just too much interference for it to actually?
That's a really good question. So the question is, could you run a bunch of slices in parallel to take your 3D ultrasound picture? And I imagine you could. So instead of using, remember that 1.5D transducer that had a set of elements along the azimuthal direction as well as in the elevation direction? You could probably excite 2 slices simultaneously, or 3 or something like that, using that array, right? And then the issue would be, I think, interference. Like you would get, because the slices are very close together, I think a lot of echoes would start interfering with each other. But this is beyond my knowledge as to what the resolution would be on that. My understanding is that the 3D is done 1 slice at a time. So you get a slice, move the whole thing, get another slice, move the whole thing, get another slice. And, but, one could assume you could reprogram or program the array to take your focal point and move it around in a two-dimensional trajectory that may be more efficient than, say, parallel slices, right? I don't know. That's a really good question. That could be one of the deep dive things that we look at with papers and look up, like, what's the state of the art in 3D ultrasound for acquiring data most rapidly. Okay, again, this is looking at Doppler signal, which is used very often in echocardiography. In fact, you usually take Doppler data on every case, every patient. And what's being done here is we're looking at flow. This is velocity, remember? This is velocity towards the transducer, velocity away from the transducer, and this is 0. The direction chosen is the direction down and into the left atrial appendage. So this is a little sac of tissue, or a little sac of blood, I'm sorry, that sits right next to the left atrium, and it's connected to the left atrium. It's almost like, well, it's an appendage, right? And so basically the problem with this appendage is that it can sometimes harbor static blood. If the velocity in and out of it is not sufficient, is insufficient to clear the blood out, you can get thrombus formed inside this appendage. And then if the thrombus escapes, it's now in the left side of your circulation. That is a place you do not want thrombus, because it's on the left side, goes into your left ventricle, comes out your aorta, and where's it going to go once it gets out your aorta? Where's the first place it could go? So it comes up to the aortic arch, and it goes up into your brain, right? So you have vessels on the top of the aortic arch that are directly feeding up to your brain, right? Those are your carotid arteries, and they come off the top of your aorta. And so the clot would go up one of those, and it would cause a stroke, right, which is ischemia of the brain. So you don't want static blood in this chamber, and so oftentimes they take Doppler to look at the velocity in and out of that chamber. Now, I've looked at this in some detail with a little bit of research with CT and looking at the echo data. These data are really not that reproducible. So while they take these measurements, the correlation of these measurements to how much blood actually gets ejected out of that chamber is not that great. We can look at that in some detail if you wish. So here's an example. Is this let's see if this is a video. No, that's not a video. So this is an example of a left atrial appendage, and this is the left atrium, this is the mitral valve, left ventricle down here, right? The appendage sits on top here, and that signal right there is not a good thing. It's a high reflection of some object that is sitting inside the left atrial appendage. That is a clot or a thrombus, right? So you can directly visualize those. And echocardiography is used all the time before somebody undergoes defibrillation for atrial fibrillation. So if your heartbeat is very irregular and you go to the hospital and it turns out you have atrial fibrillation, that means your atrium is not contracting in a synchronous way. It's sort of randomly electrically being depolarized, and so it's just sitting there. Your ventricle still continues to beat, but it beats in a very irregular timing. And that's called AFib, or atrial fibrillation. One way of getting out of AFib is you take paddles, electrical paddles, you go poof, put a big voltage across the heart, and that resets the atrium, and you go back into sinus rhythm. That works about 50% of the time, so it's worth trying, right? Because you put the patient back in sinus rhythm. Before you put the patient back in sinus rhythm, you want to make sure you do not have thrombus here, right? Because in the AFib case, all the blood in the left atrium is just a conduit. It's moving to the left ventricle, but it's not really getting ejected directly and mechanically out of the left atrial appendage. But as soon as that patient goes back into sinus rhythm and the atrium starts ejecting in a normal way, this thing can squirt out. And so you do not do it. You do not defibrillate the patient if there's a thrombus here. So the first thing, what do you do then? You take the patient away for 4 days or whatever, and maybe it's a week, and you put them on drugs that dissolve clots. So these are blood thinners, and you do that first, and you come back and you make sure that thing's gone before you defibrillate the patient. So that's where echocardiography as an imaging technique gets inserted into a critical patient care pathway. You've got to get this call right? You can't miss this one. And just say, oh, looks pretty good. I think there's no signal there. There's a little funny noisy thing, but I don't think it's a thrombus. Well, you want to be damn sure it's not a thrombus, right? So this is where image quality and everything comes in, because it really counts, right, to make that call right. And this also is an example of what is the downside of a false negative call. So the downside of a false negative call is very high, because you defibrillate a patient who has thrombus, right? So there's high risk with that call. What's the downside of a false positive call? I put the patient on an anticoagulant drug when they didn't need to go on it. That's not terrible. They're going to survive that one, right? And they're probably not going to have a stroke. The only risk there is if they're really old, they might, and they're prone to an aneurysm or a bleed or something like that. They might bleed somewhere in their body, particularly in their head. It would be terrible, right? So but that's a fairly low percentage risk. The higher percentage risk is if you miss it, if it's a false negative, and you defibrillate the patient, the thrombus comes out. And then that's not good. You have not done your job, right? So that's where, you know, all of this ROC curve analysis, you need to multiply those numbers, false positive and false negative, also by what is the downside of making one of those erroneous calls, right? So this is, we've been looking at echo. This is not echo. This is CT. And this is, actually this image was obtained probably from 2 heartbeats that were separated by 1 beat. So, because the detector on this scanner actually is only 8 centimeters. It's not the big detector. It's like a half-size detector. And so you go boom, boom, and you get 2 volumes, but there was enough contrast in this case, and the heartbeats were identical. You can't even tell there's 2 volumes were taken here. What it shows very, very clearly is sort of normal ventricular contraction, but also that thing right there is the left atrial appendage, right? And it shows you how much it's actually contracting on each beat, right? Which is pretty cool. This is something that is not commonly done for patients. So if you look there, it's full of blood. There, it's not, right? It's ejected about 50% of the blood there. This is not done clinically to determine whether or not a left atrial appendage is functioning normally, because it's too new to be in the clinical pathway, right? What's done usually is a transesophageal echo. So you actually swallow the probe down your esophagus and they look up at your atrium, right? It's not terribly pleasant, but it's very accurate. But also you can see in this data, you see very nice depiction of the surface of the left atrium. So this signal, this gold signal here, is blood. And the reason it's very bright is because we put contrast in the blood, right? So it casts a really strong shadow on CT. Okay, any questions about that? Yeah.
For thrombosis, are they generally are there any cases where they're so severe that you have to do surgery instead of administering drugs?
Yeah, if the thrombus doesn't clear, if you give them drugs, say for a week, 2 weeks, and you come back and the thrombus is still there, somebody has to go in and get it, right? And you can imagine, I mean, just make up ways that you could do that, right? The most invasive is surgery, cut things open, drag the thrombus out, sew everything up, right? Another way would be if, say I had a really nice catheter that could suck that thrombus out of there, I would go in with the catheter and just sort of suck the thrombus out bit by bit by bit by bit, right? And hopefully not generate any more thrombus. And then there's other inventions, devices, where if you're trying to do that at one location, what's the worst thing that could happen if I'm noodling around with my catheter to try and suck that thrombus into the catheter? What's the horrible situation that could happen there? Say that again? Well, I could get my catheter stuck against the hard wall. That's a bad thing, but it's not the worst thing that could happen. If I'm watching, okay, let's just say I'm watching on the fluoro. I've got my catheter. I've got it on the thrombus, right? And we're in the left atrium. What's the worst thing I could see? I'd see the thrombus go off my catheter. Oops, I dropped it, right? Whoosh, down it goes into the left ventricle. Ah, right? And then you try and chase it. You're not going to catch it, right? So that's the worst thing that could happen, right? So how do you prevent that damage from that? Let's put in another device. What should we put in such that that won't happen? When you're playing baseball, And you don't want the ball to go in the swimming pool. What do you put there?
A net.
Big net, right? So let's put in a catheter that has some kind of parachute net that's distal or downstream from where you're going to do all your action. And then if you drop it or it comes off, it'll get caught in the net, right? And then you go over to the net and try and pick it up, right? So there's tons of, that's the thing about interventional cardiology. There are a gazillion tools that you can invent that will make life better for people that have problems, right? And there's literally thousands of tools that have been invented, and many hundreds of those tools are hung on the wall inside a cardiology interventional suite. Every time they try and get something done, they look over and say, okay, what are my tools that I'm going to use here? It's a really nice sort of functional branch of medicine that engineers can really make a huge contribution to. Okay, so when you see myocardial ischemia on echocardiography, the way you recognize it, usually, is the muscle wall itself stops contracting 100%. It might drop its contraction amount to 50% of normal contraction. And it does it in a regional way. It doesn't do it over the whole ventricle all the time. Sometimes it does, but if you have regional ischemia, you will see on the echo that region will not be contracting well. And so when people read echo, going back 5 slides, they click through those regions and tell you how each one is doing. Or they say all regions are normal except, and they'll tell you the region that looks like the wall function is low. And that's all done visually. They just look at it, see whether or not on the echo the muscle is contracting normally. And if they believe it is not, just through their looking at it, they'll tag that region as abnormal. And when they do that, they have in mind that these regions, as we saw that 2-chamber, 4-chamber, and the parasternal view, sample the long axis and sample the myocardium in different regions, and then the 3 short axis ones. Remember those 6 regions, 1, 2, 3, 4, 5, 6? The color scale here is the probability that that region is fed by a certain coronary artery. So we have 3 main coronary arteries. The right, it comes off its own coronary cusp here and goes over the right ventricle. And then the left system, there's a left main that comes off an adjacent coronary cusp, goes over the left ventricle. It splits into 2. One is called the circumflex here, which is kind of like the right coronary, only on the left side. It goes across the top of the heart and then towards the back of the heart. And then there's a vessel that runs right down the front of the heart, and that's called the LAD, left anterior descending coronary. Those are the 3 biggies, right? And so if you have a blockage in one of those segments of your coronary artery, either the proximal right coronary artery, proximal means close to the aorta. So this is proximal, this is distal away. So something here or something here, you've got big troubles, right? As you move down or you move distal away from the origin, and now I have, say, a blockage here, well, I'm going to knock out a much smaller piece of tissue because the flow will only be limited distal to where my blockage is. And so these regions, these are very loose labels because obviously, the heart is grown by a biological mechanism, and so that which coronary arteries feed what regions of the heart varies from person to person. But the kind of order of the map, like the order of those zones, is given in this diagram, right? You'd never see it flipped, right? So this basically is fed, by the left anterior descending or the circ, right? This segment, oh, sorry, let me put on this segment here in the two-chamber view is always fed by the right coronary artery. So if you see wall motion abnormality here, right down on the posterior wall, then that's going to be from the right coronary artery. As you go right down to the posterior wall and then out to the lateral wall, you get a mixture. So this could be either the circ or the right, you know, et cetera, et cetera. And so these are the zones in which people look for abnormal ventricular contraction on echo and try to tie it back to ischemia from a specific vessel. This map with the abnormal contraction and the EKG from the patient, if you have an EKG and the EKG is showing abnormal activity, abnormal voltages, oftentimes the structure of the EKG can also tell you where the ischemic region is on the heart. And so it will be an additional clue as to which vessel is causing this ischemia. If you see that, right, normally you just go to the cath lab. If you have EKG abnormalities, echo abnormalities, and some of your blood work shows that you have indications of muscle dying, then you just go to the cath lab and they're going to put a catheter in each one of these and illuminate the vascular tree. But then oftentimes when they do that, they see a lesion here, a lesion here, a lesion here, and a lesion here. And it's like, which one of those lesions is the one causing this person this ischemia and this pain? Which one should we treat first? Sometimes you don't treat them all. You just treat the culprit lesion, right? And they go in and try and relieve the ischemia by treating that lesion with a stent. So here's this is a really good YouTube description of what stress echocardiography is, and we can describe it quite quickly here. In stress echocardiography, recall that ischemia is usually induced by asking the heart or asking the vessels to provide more blood flow than the baseline. Most people, if they have baseline pain and ischemia, if they're just sitting in their bed and they have pain and ischemia, most of the time they're going to go to the cath lab. They're going to have ECG abnormalities and things like that. If, on the other hand, it's somebody who is relatively fit/normal, and yet when they cycle on the weekend, they're 30 miles or whatever, they start developing pain when their heart rate hits a certain level, that's basically a stress-induced ischemia. My personal theory about why exercise prolongs life expectancy is that you are constantly stress testing yourself, right? So you're basically at a certain level or demand, and you detect your first ischemia up there instead of down at baseline. Right, where the disease has to be pretty darn severe to cause baseline ischemia. It doesn't have to be that severe to cause ischemia up at a high level of activity. So, and I've had a number of friends in their 50s who have gone through this. They know that there's something wrong. However, their EKG is absolutely normal, and they can't generate a positive nuclear stress test, for example. An echo stress test, the way you do this is you put somebody, they can be on a bike or you can give them a drug. Let's do it with the drug because it's the easiest. So they're lying on a table and you take a rest echo study. So you look at the wall motion or the contraction of the muscle in all of those regions that we talked about. And if it all looks normal, well, cool. You then give them a drug, and this drug is called dobutamine. And what it does, it's like epinephrine. It creates much stronger contraction or contractility in the myocardium. And so the heart itself starts to beat it goes a little bit faster, somewhat faster, but it contracts with much more vigor. And what this does is it raises the demand for blood, and then if the demand is not met, you will see that the first thing that happens is the wall motion, the increased contractility of that piece of tissue will drop. It'll stop contracting. And it looks quite obvious when it happens. You go, whoa, we just lost the anterior wall, right? It's not keeping up with us here, right? And interestingly, that happens actually before ECG abnormalities. And so stress echo is a pretty sensitive test for detecting myocardial ischemia when you need stress to generate that ischemia. So there, 1 million of these are done a year, stress echocardiography. You need to do it in a center that is good at doing stress echocardiography, because you need a good tech, you need the appropriate drug regimen for generating the stress, and you need really experienced physicians to read the side-by-side echocardiograms. So you actually look at the parasternal view of the patient at rest and during stress, and you look at them side-by-side, and you ask the question, is the one at stress any different, other than the fact that it should be contracting much more vigorously, right? So that's how it's done. They literally do that. They put them up side by side, the rest and the stress, and they ask that question, right? And so they'll do it in different views, in the short axis view and long axis view. Okay. Don't know. Let's see. Let's go to this one. That's 17 minutes and 21 seconds. Let's go over here, see if we can see what this is. What did I say, 17 minutes? Look, it's 55 minutes, man. There's a lot to learn about stress echo. Okay. No, I'm not making sense of this. Which is which? So these two, post, GST, GST. Okay. So these are the same view, all right? Both of these look like they're post-stress, right? And you have to ask the question, is this heart contracting normally? Right? And you can see why it's a little tricky. Right? It's the sort of signal to noise of the system for making this call isn't the best. Right? But it looks to me like there's possibly a reduction in shortening. And you look at this, there's a real reduction in shortening here, right? Well, compared to here. So you see how the heart's contracting down normally here, and then post-stress, that wall basically stops contracting. So compare that motion to that motion. And so that would be a positive stress test. And, it's done that way. It's done visually. People don't really, do things quantitatively by measuring wall thickening or anything like that. They just look at it and become experienced at doing that. Okay, let's look at mitral valves. This is, again, remember we looked at this in an earlier lecture. What can go wrong with the mitral valve? The mitral valve is here to stop blood going back towards the lungs when it's supposed to be going out the aorta. And if the mitral valve breaks down for whatever reason, you get blood going out the aorta plus blood going back towards the lungs. And that will reduce the, basically the output of the heart. So your cardiac output will go down. But it'll also basically take more energy to push blood through this valve the wrong way, and the muscle itself will start to fail, and all these bad things happen. So a normal mitral valve looks like this when it's closed. It has one essentially opening. It looks like a smile. And this opening opens like this when blood goes this way, and it should be coapted or shut during left ventricular ejection. Mitral valve prolapse is the widening of the entire valve base here, such that these leaflets cannot make it to touch each other. You can have degenerative disease such as a loss in the chordae here, which are holding on to the valve. They may break, and then one side of the valve will flail, and you'll actually see that this goes up and blood is coming back this way. And then functional is when the entire ventricle itself expands, causing the mitral valve plane itself to expand such that you can't co-opt the valves. And so this is a classic case of mitral valve regurgitation. Let's go take a look at that. Should be up here. Right? So here you can see this is probably functional, because if you look at the left ventricle, it really is not contracting terribly well, i.e. the fraction of the volume of blood left in the left ventricle after it's finished ejecting is very high. So the ejection fraction here is probably like 10%, The muscle is shortening, but not that much. Here's the mitral valve, and you can see that there is color going this way and then color going this way, away from the transducer, which is the wrong direction. It's not supposed to be going that way. And so that is a mitral valve jet. Now we saw this before, what an aortic valve looks like when it's healthy. And as people get older, their valve gets sort of encrusted with calcium, and that hardening of the valve can cause a problem with coaptation. And so when it's shut, it may not shut completely because of that problem. And then when it's open, in a young person, your all's age, would look like this, but in an old person, it may not open the whole way either. So this, area is reduced compared to this area, and that's a critical measurement, is what is that area when it's open all the way. If it doesn't open all the way, blood, because you want to keep your cardiac output the same so that you don't faint, blood has to get through here at a higher velocity, so you get this really fast jet. The muscle needs to push it through there at a higher pressure, and so the ventricle starts, doing curls basically, and it gets thick. The muscle builds up, so you look like a rower for a little while, right? People who row, they get these thick, big hearts because they do so much cardiovascular exercise, which is called athletic hypertrophy, which is not bad for you, apparently. But then eventually, this stops thickening, and it starts failing and gets thinner and thinner, and the ventricle will become spherical in shape. And on your problem set, the point of one of those problems was if your heart is normal and it's a cylindrical shape, right? And the walls have to thicken to squirt blood out, versus if your heart is a sphere, right, and it broadens out and becomes a spherical shape and then has to thicken what does that wall thickening look like in those two cases? And it turns out that if it's a sphere, right, the wall thickening required to eject the same amount of volume is lower. And so you can get away with a lower amount of thickening. And so when the heart fails, it changes its shape from sort of a bottom of a football and more conical or cylindrical into a spherical object. So this is transesophageal echocardiography of basically velocity through the aorta. And you get these, if you're willing to swallow an echo probe and put it in your esophagus so that you don't have to look through the ribs, you're already inside, and you just look up at the heart from your esophagus, you get these really nice pictures. They look like this, right? And so that's why TEE is done in many patients if you really need really good data. And you know, here we're measuring velocity through the aorta with that data. And here's, again, 3D echo of an aortic valve. And it looks as though we've got a fairly good, I don't know, it doesn't look like that's too much of a jet, right? This little thing here doesn't look too bad, right? Okay, so here's pulmonary hypertension. This is when you're basically the ejection of the blood to the right side of your body. Basically, the heart has to work a lot harder because for whatever reason, the flow of blood towards your lungs is being impeded. And it can be impeded by you know, the fact that the vessels down in your lungs are basically contracted, or you can have a lot of small thrombi in your lungs, etc. And so this causes sort of a pulmonary hypertension or high blood pressure on the right side. And in that case, you get a very large right ventricle. So here's the normal. Remember, this is a parasternal view. This is the left atrium over here. This is the left ventricle. And here's the aortic valve. You can see the septum is bent all the way into the left ventricle here. And that geometry, so when great thing about echo is you don't know, like when the person's there and they're having a hard time breathing, you don't know what's going on, and you put this on and all of a sudden, boom, you know what's going on. Their right ventricle is huge. It's impinging on the outflow tract of the left ventricle, and in fact, it could even occlude the outflow tract if this mitral valve leaflet hits this wall here, right? So their right side is enormous, and that's what's causing their symptoms more than likely.